Thank you very much for the kind introduction, and thank you everybody for coming this morning. And I want to start by thanking Chris, David, and Peter Ree as well too for the invitation to come back to Phoenix. It's really a pleasure to be here in this meeting and in this beautiful place. So I was invited to talk about a recent paper that we had published in the Canadian Medical Association Journal, and that's the first randomized control trial on damage control resuscitation. So because I'm sure that it just came out 2 months ago, I'm sure that most of you have not read it or even know it exists. So instead of having a formal talk, why don't we just read the paper together? Let's read it. It's instead of a formal talk. So here we go. I have nothing to disclose except my many thanks to Jeannie Callum and Barton Nascimento. Those were the two instrumental authors on this paper, and as well as the other co-authors that are listed underneath. So this was a very difficult trial to do, as you can imagine. So let's start. I'll take for granted that everybody here in this room or everybody here at home that's watching this presentation know what one-to-one-to-one resuscitation is. We're actually going to have the privilege to hear Dr. John Holcomb, who's one of the fathers of this resuscitation strategy, talking later on today. And this resuscitation strategy aims at the trauma patient that's bleeding, and it's bleeding a lot. It's aimed at patients with significant, massive hemorrhage. And the goal of this resuscitation strategy is to correct the early coagulopathy of trauma. That's something very recent. We just realized that thing really exists in this century. And also to correct the volemia. And what's interesting about this resuscitation strategy is that it uses bloods, a blood-based resuscitation. And actually, it recommends that you should withhold giving too much crystalloid. Hold on the normal saline or Ringer's lactate. There are many studies on DCR so far, and almost all of them show an incredible benefit, show an enormous reduction in mortality, but all these studies to date are retrospective and they do have limitations. Despite this lack of good evidence, DCR was quickly adopted, particularly in North America. I'm sure that most of us here work in a trauma center that use DCR to resuscitate our massively bleeding trauma patients. But there are problems. It's not perfect. Not only it's lacking prospective evidence, but also it requires that you should have thawed AB plasma to give to your patient. The problem with AB plasma, AB anything, is that there are only 4% of the population has AB blood. So AB plasma is the least common plasma that you're going to find. On top of this, certain countries like mine, like in Canada, you cannot give plasma from female donors. You can only give it from male donors because of trolley. So it's not an easy strategy to implement in your hospital. And many places have actually tweaked a little bit the DCR to be able to adapt to their reality, but most trauma centers in North America today use DCR to resuscitate. And another problem too is identifying who are the patients who will need massive transfusion. It's not easy, and often you end up starting patients on blood, and then 2 units later they start bleeding, and there we go. They got blood when they would not need to get blood. So that was the background for us to say, look, we have to do a prospective study, but this is going to be hard. It's going to be expensive. So before we go to a full-blown randomized control trial, why don't we do a pilot study? Is it feasible to do a study on this current situation where everybody believes DCR works? Everybody's using DCR works. Can we do a study on one-to-one? Is that going to be possible? Is it feasible? And that's the question that we put for our study, and also we decided to look at safety since it's a blood-based study. So this study was done in a single hospital at the University of Toronto, in Canada. It was unblinded, and you're going to see why. It's very difficult to blind when you're giving blood to these patients, and had a 2-arm design. I'll talk about the 2 arms very quickly. Who were the patients that we wanted? We want bleeding patients. We want patients that were bleeding a lot. That's what we wanted. We don't want anything else. So they had to be adults. Patients with significant bleeding, they get hypotensive, so they should be hypotensive. They should have evidence of bleeding. And the physician in charge should say, I think this patient is going to need a lot of transfusion. That's the best way we knew how to predict who's going to need massive transfusion or not. But then we tried to define what expected massive transfusion meant, and we told the doctors, look, if you think your patient is going to need 4 units in 2 hours, that's massive. 10 units in 24 hours, that's massive. Please call us so we can enroll the patient. I'll tell you, it was a disaster. Like doctors, we don't do things usually rational, and when we have this type of patients, we don't want to call the research team. So actually, very quickly we learned that the best way to find patients who will need massive transfusion was to put an alarm on the fridge that has blood, uncross-matched blood in the emergency room. That's true. We put an alarm there. So everybody, the doctor, the physician, the surgeon, went for uncross-matched blood. An alarm would go off in the blood bank. And then the blood bank would quickly try to find out who the patient was, and then the patient would be enrolled. And actually, you know what? When we look back, that was a stronger indicator of need for massive transfusion than any other one that we could find. So usually doctors do things by gut instinct, and that's what we learned. So, and who do this exclude? We want fresh patients coming off the street that were massively bleeding and would need massive amounts of blood to be resuscitated. That's what we want. We did not want patients who had been transfused before, who took too long to come to us, patients with head injury. We didn't want head injury because head injury kills more patients than bleeding. So there will be a strong confounder here in our study. We didn't want patients with cardiac tamponade because they bleed 250 cc's and they go hypotensive. We don't want that. We want patients who are massively bleeding. So we excluded everybody else, and we excluded those who were moribund, those who we think will not survive the injury. And then another methodological issue is most of these patients cannot give consent. So fortunately for us in Canada, there is a proviso in the rules that say that we are allowed to enroll patients into a study and get their consent later. So that's the proviso that we use, and this is Article 3.8. We got this approved by research ethics, we got approved by the university, and this gave us the authority to enroll the patient into the study and then as quickly as possible get consent from the patient or from a substitute decision maker. And that's how we're allowed to start the study. So the alarm would go off in the blood bank. The blood bank would contact the research team. The research team would check whether the patient was eligible. If the patient was eligible, then the blood bank had an envelope that they would tear and get the thing and say, well, look, this patient's control or this patient's in the 1-to-1-to-1 arm. And then they would start preparing the blood to go to the blood bank. So there was a delay between the patient being enrolled and the patient actually start getting blood. And this was done by computer, as an allocation by blocks of 4, and stratified by blunt versus penetrating trauma. And these are the two groups. So group 1 is the patients who got 1-to-1-to-1. So what happens here is that we didn't have thawed plasma. We didn't have thawed plasma. Is that here? Oops. Uh-oh, now I really... Okay, so we didn't, they're trying to put it back. We didn't have thawed plasma, so the patient would start getting RBCs, uncross-matched RBCs, until the plasma was thawed and sent to the emergency department or to the operating room or wherever the patient was at that time, or angio suite. And then the blood bank would prepare boxes with 4 units of red cells, 4 units of plasma, 4 units of platelet, and would keep on shipping that down wherever the patient was. So actually an important part of the team was the porter who was actually running around the hospital, getting the blood and taking to where the patient was. And on this group, no need for lab. Second group was the control arm. So the control arm, we tried to reproduce what we thought everybody did at that time. That's, in my opinion, a mixture of intuition and lab tests. So these patients are the ones that we use our massive transfusion protocol, and what we require of them is that the surgeons should order blood work Q2 hours, every 2 hours, and we expected that they would use those labs to make decisions. We know that's not what happens in real life, but we try to mimic real life. So, and if the hemoglobin was below 70, they would call the blood bank and say, I want red cells. If the PTT or INR was above 1.8, they will say, I want plasma. If platelets were below 50, they'll say, I want platelet. And only then they would get blood. So in group 1, blood will come to them. They would turn around and there'll be a box right behind them full of blood. Control arm, they had to call the blood bank and say, I want blood. And the blood bank would say, which one? And they'd say, I want red cells and I want platelets. So those were the two groups. And the question we had here was, can we make a study like this? Is it possible to do a study like this? Is it possible in the end to have two groups that are different? Or what's going to happen is that on the control arm, the surgeons who love DCR are going to just call for everything and going to give everything. And the end's going to be the same thing on this one. So our first primary outcome was feasibility. So can we do it? Can we, in the end, have two different groups? And we decided that feasibility would be the percentage of patients in the group 1-to-1 that would receive 1-to-1. And then we looked at many safety outcomes as well, too. There was no sample size calculation. And the reason is in 2009, there are not enough studies to tell us what the outcome should be. Actually, as I told you, this is the first prospective randomized control trial. So we said, look, we get about 36 to 40 patients a year, so maybe let's do 2 years, let's get 70 patients. So 36, then we're going to miss a few, so 70 is good enough. And we did not even set up what will be the difference. We just said, let's see if we can find a difference. And that apparently is okay with the epidemiologists, they approved it. And then we would look at 28-day mortality intention to treat. Then there were all this very complicated statistical tests that fortunately for us, we had a group of statisticians work with us, and we have a safety monitoring board that was independent, and actually, a priori, they had the authority to exclude patients. So if you put a patient that was dead, or that was with brain coming out, or was on Coumadin into the study, the DSMB had the authority to pull this patient out of the study at a later date. So let's see the results. So here it is. So the study was done between 2009 and 2011. In this period of time, in my hospital there in Toronto, we had 203 patients that were assessed for eligibility, 78 were randomized. So we're not far from the mark. There we go. We thought 70, and we got 78. And then there was split. 40 patients went to the 1-to-1-to-1. 38 patients went to the lab-guided, intuition-guided, traditional resuscitation, whatever you want to call it. And then we had, to our surprise, 3 patients that refused, including one that was Jehovah's Witness, that we gave him blood. We did not know until then. And we had 6 that were excluded by the DSMB, and most of them were excluded because they were erroneously entered into the study, like they had evidence of severe head injury, or they were on Coumadin and things like that, so they excluded. So in the end, we had 37 patients in the 1-to-1, and 32 patients in the lab-guided. But when we look at mortality, we included 40 patients in the 1-to-1. So there was intention to treat. So everybody who was put in the 1-to-1 group got analyzed for mortality. And here's the demographic. So it's a small study. It's about 69 patients split into 2 groups. And we're surprised how equal they were, in fact. So if you look at ISS, so where's ISS? There, it's do I have a pointer? Okay, so maybe if we look here at who received 1-to-1. So there was the first question that no, sorry, let me go back here, I think. Okay. So we look at the characteristics of the 2 groups, and I'm still trying to find the ISS. There it goes. On top of the score 3, so it's here, ISS, 35, 35. Let's see another one, Glasgow Coma Scale, 14, 13. Systolic blood pressure, 81, 80. So the 2 groups are actually quite well balanced. That's surprising. Usually in a small study, you get a few patients who are out of the scenario. When we look at their characteristics, their lab on arrival, pH 713, pH 718, INR 1.2, INR 1.4, platelets 200, 190, hemoglobin 99, 90. So again, the two groups are in fact quite similar. And then was question number one. So question number one is, could we separate them? Could we separate them into two groups? And in fact, we did. We can see that for the patients on the group 1 to 1 to 1, if you go for who got 1 to 1 to 1, almost 60% of the patients in the 1 to 1 group actually end up getting 1 to 1 versus only 6% on the control group. And when we only look at 1 to 1, just plasma and RBCs, actually 3/4 of the patients, the 1 to 1, got 1 to 1, while only 20% about the patients on the control group got 1 to 1. So in the end, we had, in the 1 to 1 group, we have 1 to 1 to 1. And in the control group, if you go by ratio, actually they have 2 to 1. That was very interesting. You let the surgeons do whatever they want, and they end up with a ratio of 2 to 1. Right? And then what we had here, we had that time that took between the first unit of red cells to plasma was about 60 minutes. And that is quite a significant difference. And we find out that most patients were included actually because we used the uncross-match RBC to enter them. Lab tests were done virtually in almost everybody, as we expected, and they were repeated Q2 hourly in a good, almost 90% of the patients on the lab group. So it did work. We're able to have two distinct groups. How about safety? So the first thing we look at was safety, and we look at mortality, all-cause mortality at 28 days. And what we found here was actually quite surprising. The mortality on the 1 to 1 to 1 group was 2 times higher than the mortality in the control group. And here where I say stop. This study was done to study feasibility. This is we're just also look at mortality and other things. This was not a study aimed or designed to look at difference in mortality, but we were surprised when we saw this. So it has to be interpreted with a lot of caution because a small study, will answer this question appropriately. But we were surprised to see a much higher mortality in the 1 to 1, and the time to death was 3 hours in the 1 to 1 group versus 4 hours in the control group. We also look at which group got its coagulopathy better correct. Which one do you think got 1 to 1 got much more blood than the group 1 than the control group? Who do you think had the coagulopathy better corrected? 1 to 1, yeah, exactly that. So giving more blood ends up getting better numbers in the correction, and the bleeding-free hours in the first day was about the same in both groups. And everything else we looked were very similar. So we look at ventilator-free days, we look at the length of stay, we look at ICU admissions, and basically the results are about the same on both groups, and all other co-interventions, who need surgery, who need angio, time to surgery, decompressive crani, amount of fluids, amount of cryo, tranexamic acid, and so on, and there was no difference between the two groups. And then another one that we had put a priori to study was ARDS. So instead of just measuring how many patients got ARDS, what we measured was ARDS-free survival. So we want to know how many patients that survived did not have ARDS, and this is, according to this statistician, a better way to assess, because we knew that blood was associated with more lung edema, longer ventilator days, and so on. And then we did a Kaplan-Meier curve, and what we saw, this is the control group, and this is the 1 to 1, and looks like there's quite a distinct separation, but this did not reach statistical significance. And again, I caution you that this study was not aimed at any clinical trial, any clinical outcome was aimed at looking at feasibility. And this is how I see the results of this trial. So it is, number one, is it feasible to do a study? Is it possible to have a study, even in a place who likes DCR, that you can separate two groups? If you use 1 to 1, one thing that's for sure is that you will waste more plasma. So in the 1 to 1 group, 1 unit out of every 5 went to the garbage, and that was just because plasma was prepared, not used, and for some reason not reused. I'm sure that we could have probably a higher compliance if we had pre-thawed plasma, but we don't. the time between the first unit of red cells and plasma was about 1 hour, and that was because the first unit of RBC was the one who actually put the patient into the study. And interesting, in 3 patients in the 1-to-1 group, the anesthesia refused to give platelets. They look at the numbers, and even though there was a study, they refused to do it. So this study didn't have pre-thawed plasma. That's a limitation, although most of the world does not have thawed plasma. So I find that probably our study is very generalizable. We did not measure whether the surgeons or the physicians use the lab to make their decisions, and this study was done for feasibility. So caution with the clinical results. Be careful how to interpret them. And I think that the proper study is made and calibrated and done to show actually these results for sure. We'll show mortality, we'll show ARDS. So in conclusion, 1-to-1 is feasible. It's possible to separate 2 groups. It's possible to do an RCT. If we decide to full implementation of 1-to-1, there will be a challenge to the blood suppliers. There will be patients on the 1-to-1 receive more blood, and also there's more waste of plasma. And I look for the results of the proper study when we're going to know the clinical outcomes of these patients. Once again, I thank you very much. A privilege to be here in Phoenix. Thank you.